Good morning, and welcome to this Oncology Data Advisor interview featuring our coverage of the 2025 ASCO annual meeting. I'm joined by today's guest, Dr. David Madge from Arthur Child Comprehensive Cancer Center. At ASCO, Dr. Madge is presenting his poster titled Second-Line Outcomes in Metastatic Renal Cell Carcinoma, the Role of IMDC Prognostic Factors After First-Line Immunotherapy. And today he's here to tell us some more about this research, as well as some insights for World Kidney Cancer Day on June 19th. Dr. Madge, thanks so much for coming on today.
Thanks for having me.
To start off, would you like to introduce yourself and share a little about what you do?
Sure. So I'm David Madge, and I'm a staff oncologist at the Arthur Child Cancer Center in Calgary, where I treat both GU and breast cancers. And my areas of research include adverse effects of drugs, as well as real-world data.
Awesome. Looking forward to hearing about this poster today. So for background, would you like to tell us what are the IMDC prognostic factors and how are they used in metastatic RCC?
Sure. So the IMDC is the International Metastatic Renal Cell Database Consortium. And so this is a group of researchers who use real-world data in kidney cancer from around the world. And we do lots of projects with real-world data. The IMDC risk factors were first characterized back in 2009. And these are a mixture of kind of clinical and lab factors, including time from diagnosis to the start of first-line treatment, performance status less than 80%, hemoglobin less than normal, calcium more than normal, platelets more than normal, and neutrophils more than normal. And this mixture of factors is prognostic in how patients do with first-line therapy. It was first described in the VEGF TKI era, and since been validated again in the more modern immunotherapy era. And it's important in a number of different domains because one, it helps clinicians get a sense at start of therapy, are people on a more favorable risk, an intermediate risk, or a poor risk group? And that has got implications on what their long-term survival is going to be. And it also helps define which therapies they're eligible for. And so some notable examples of that are ipilimumab and nivolumab are approved in the first-line therapy, so in the first-line setting, but only for people who have got intermediate or poor risk disease. Same thing is true of cabozantinib in the first-line setting as well, only in intermediate and poor risk disease.
Great, thanks for the overview. It's always helpful in understanding. So for this project, why did you decide to investigate their role specifically in the second-line setting?
Yeah, so we use IMDC risk factors a lot in establishing those risk groups in the first-line setting, and that helps in the selection of which treatments we're going to use in the first line. And from there, you're often on a little bit of a path because your first therapy often dictates your second-line therapy. But we had done a paper, well, the IMDC had done a paper a few years ago looking at risk factors in the second-line setting and trying to see if different treatments were more effective in certain groups versus others. And so I was interested in, did this still hold true in the immunotherapy era? And in particular, I was really interested in, well, what happens if you change groups? What happens if in the first-line setting you're an intermediate risk, but now in the second line now you're favorable risk or you're poor risk? Does that actually affect your long-term survival or not?
Great. And then how did you and your team go about designing the study and what did it involve?
Yeah, so the IMDC maintains a database of over 10,000 patients that we've collected real-world data from a number of centers. We've got fantastic collaborators from around the world. And so that gives us a really rich data set to look at. And so I think we had somewhere on the order of 1,100, 1,200 patients who'd received first-line immunotherapy, and now we're getting second-line treatment. We had kind of good data on them. And so this is a retrospective analysis of that data where we captured baseline characteristics, including IMDC risk in the first and second line, response rates, treatment duration, overall survival, and then we analyzed that data.
Perfect. So what results did the study produce?
Yeah, so we produced a number of different results that I think are interesting and important. I think one of the kind of key things for this is now we've got new benchmarks for the real world of what prognosis looks like if you're favorable, intermediate, and poor risk. And so that's roughly 40 months if you're favorable risk in the second line, 26 months if you're intermediate in the second line, and about 10 months if you're poor risk in the second line. So that's kind of useful for people when they're counseling patients. And then a few other things we found. So one of the big questions out there is in the first line, should we really be looking at preferring combination immunotherapy with nivolumab ipilimumab, or one of these immunotherapy TKI combos, of which there are a few. And this is kind of an ongoing debate that we're having in the world of kidney cancer. And one of the important things we found is that it doesn't seem to matter which of those first-line treatments you have in terms of what your second-line risk is. So you're not more likely to become favorable risk in the second line if you started with ipi nivo. You're not more likely to go into poor risk if you get IO TKI or any of those kinds of things. So that's kind of reassuring, actually, that we can kind of focus on making decisions in the first line that make sense at that time without being as worried about what the longer term implications to that patient are going to be in the second line. And then there's a couple other things which I think are generally interesting. So most people maintain their risk groups. About 66% maintain their risk group. About 12% their risk group gets better. About 22% the risk gets worse. And the second line risk does seem to matter. So this is probably most clear in the intermediate and poor category, sorry, in the intermediate category, where we've got the highest number of patients. But patients who go from intermediate to favorable risk do better than those who stay intermediate, do better than those who go from intermediate to poor risk. So there are prognostic implications when you're changing risk group.
Great, thanks for explaining. So you touched on this a little bit, but how can these results be used to inform patient counseling as well as clinical trial design?
Yeah, so I think probably the biggest implication, at least for me, is in patient counseling. When we first meet patients and we kind of start them down the cancer journey, we give them kind of a rough idea of where things are going for them. Often we may, hedge a bet and say, well, we have to see how things go. And when we're in the second line setting now we've kind of had a chance to see how things have gone. And so I think it's important to reset things with patients, try and give them a sense of, are things going really well, going pretty well, actually? Like, are they more favorable now? Does that imply a longer survival? Or if things getting worse and now maybe they're poor risk, or before they were favorable, in the implications that can have on prognosis? That's really important for goals of care, and for planning with patients and deciding kind of what makes sense for them in their care. And then from a clinical trial design, there's a few different implications. I think one is having these benchmarks will help people design, well, how long a follow-up do I need? How many people do I need to get adequate power? Things like that, based on kind of what we are expecting. And then I think it, also just reinforces that it's really important when you're getting into a second line trial that when you're stratifying patients into that trial, as these trials often do, it's really important that you are stratifying them by their second line risk and not by their first line risk, because otherwise you may introduce a confounder into your data that you're unaware of.
So my last question for you as we wrap up today is, in honor of World Kidney Cancer Day on June 19th, are there any take-home messages that you'd like to share about this work in the broader field of kidney cancer research?
Yeah, I think the main take-home message from this work is an appreciation that this change in risk group from first line to second line does have real-world implications in patient prognosis. So it's important just to reassess that, both for yourself as a clinician and for your patients and for their counseling. And then I think, like, broader in the kidney cancer research world, it's a really exciting time in the kidney cancer research world. There's been just absolutely massive changes in how we're treating kidney cancer than were 5 or 6 years ago. There's a whole bunch of new treatments coming down the pipeline. So there's a lot of excitement in the field. There's a lot of hope in the field. And I really hope that people take that away on Kidney Cancer Day.
Amazing. That's a very exciting and hopeful note to wrap up on. So thank you again, Dr. Madge, for coming on today to share this research with us. It's always wonderful to hear about these directions in the field, and best of luck at ASCO.
Okay, thank you so much.